In this talk, we will review the field of cardiac MRI, going into some of the techniques and clinical application. There are quite a few techniques available for cardiac MRI. In fact, considerably more than we usually use in other areas of the body. And this ranges from basic anatomic imaging, such as black blood imaging for structure, cine imaging to look at ventricular function, delayed gadolinium enhancement to look at viability and infiltrative disorders, flow imaging to look at flow in the major vessels, as well as other more experimental techniques. The usage of cardiac MRI has been increasing considerably over the last few years, in part because it is the most accurate test for ventricular function. It is unparalleled for myocardial tissue characterization. It provides a safe non-contrast alternative to CT angiography where needed, and it allows for very accurate hemodynamic evaluation, which you can't do with CTA. So while CTA is proving to be an excellent test for coronary artery disease, cardiac MR is the test you're going to use for most other things. Now, there are quite a few indications for cardiac MR. Presumably the patient has already had an echocardiogram and there is additional information that is needed. So, for instance, one can use cardiac MR to look at viability, to evaluate mass and thrombus, to look at pericardial disease, congenital heart disease, and, for instance, in patients undergoing chemotherapy, to give precise, reproducible functional evaluation. Cardiac MRs can be rather time-consuming exams, and so we try to be as efficient as possible. We start out typically by doing an eGFR measurement through a finger stick to make sure that the patient's renal function is sufficient to give gadolinium, and gadolinium is given in almost all the exams. We have to start an IV, apply ECG leads, then once a patient's in the scanner, we do scout imaging, a series of cine images in various acquisition planes. We will usually do flow quantification through the aortic root and main pulmonary artery, which is helpful not just for measuring QP-QS ratio, but also for various types of valvular disease to measure regurgitation. We are increasingly doing pre-contrast measurements of T1 using acquisition techniques such as MOLI, as well as T2 star and or T2 measurements. We then give gadolinium, and this can be either done as a dynamic perfusion study to look at myocardial perfusion, or we can look at the great vessels if that's of interest. And then we will often wait 5 minutes for the gadolinium to percolate into the tissue. We will then typically acquire a series of single-shot delayed enhancement images, which are motion insensitive. We repeat the T1 measurement in the myocardium, and then we acquire additional high-resolution delayed enhancement scans. After this is all done, we push the images to a workstation for processing. In our case, we use a Circle CVI workstation, and that results in all the data we need, which is quite a comprehensive exam.